Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. I'd like to welcome everybody to once again one of our Webimas. That's the Web IMAs presented by the Islamic Medical Association of South Africa. Inna alhamdulillah nahmaduhu wa nusalli ala rasulih al-kareem amma ba'd. As most of you have seen from the adverts and from the poster that was put on, we have two very interesting speakers today, and the topic of today is the heart. So we've got a bit of tarbiyah, as is customary with our Islamic Medical Association webinars. We start with a tarbiyah, and today's tarbiyah will be by Maulana Sulaiman Mullah, who's a well-known orator and Islamic scholar, internationally traveled, and not a stranger to the Islamic Medical Association. We'll follow this up with Dr. Ahmed Vachiat, who will be giving us a lecture on the optimization of heart failure treatment for better outcomes. Before we start, some housekeeping. Please make sure that your video and your audio is off during the webinar. If you have any questions, make use of the chat box, submit all your questions, and we will try and get through as many of them as possible before the end of the meeting. If you have any trouble logging on, or if you have any trouble technical issues as such, just contact Sister Kashifa. We're all very familiar with Sister Kashifa, and she will try and address these as we go on the fly. During the meeting, there will be a post or a link in the chat box that comprises basically the register for all of you that are present today, so that you can get your CPD points. And then it will also be a little survey with 3 short questions. Please fill those questions in. It helps us a lot with feedback, and it helps us improve as we go forward. So without further ado, if you're all ready to go, I'm going to ask to load for us the first video where Sheikh Sulaiman Mullah goes and gives us some nasiha on the qalb, or the spiritual heart. Thanks,
Bismillahir Rahmanir Rahim. There is an amazing incident recorded in the books regarding Luqman the wise. Once his master told him, "Idhbah lana hadhihi ash-shat," slaughter this lamb and sheep for me. "Wa'tini bi atyaba mudghataini minha," and then select from it the 2 tastiest pieces of meat. فَجَاءَ بِالْقَلْبِ وَاللِّسَانِ. He obliged and complied, slaughtered the animal, and presented in the service of his master the heart and the tongue. The master asked him, "Are you convinced this is the most palatable pieces of meat?" He said, "Absolutely." A period of time lapsed, and now the master asked him to slaughter another lamb, but this time to reverse it around and present him with the most unpalatable pieces of meat. So he slaughtered another lamb, and believe it or not, as strange as it is, he presents the heart and the tongue for the second time. So the master is rather perplexed by this, and he said to Luqman, "I asked you for the most palatable, you gave me the heart and the tongue. Then I asked you for the most unpalatable, and you gave me the heart and the tongue again." To which Luqman the wise replied, "لَيْسَ فِي الْجَسَدِ مُضْغَتَانِ أَطْيَبُ مِنْهُمَا إِذَا طَابَ وَلَا أَخْبَثُ مِنْهُمَا إِذَا خَبُثَ." "O my master, there is nothing better than the heart and the tongue when nourished, and there is nothing more wicked than the heart and the tongue when neglected." The famous hadith of the Messenger sallallahu alaihi wasallam, which appears in Ibn Majah, in which he sallallahu alaihi wasallam said that in the body there is a piece of flesh. إِذَا صَلُحَتْ, if this piece of flesh is reformed, صَلُحَ الْجَسَدُ كُلُّ, then the entire body will be reformed. وَإِذَا فَسَدَتْ, and when it is neglected, then it will have negative implications on the entire body. Behold, beware, أَلَا وَهِيَ الْقَلْبِ, it is the heart. If you were to ask the grammarian or the philologist or the linguist regarding the word qalb in Arabic, which is the word used to describe the heart, what does qalb literally mean? Qalb means something that is ever-changing, and that's the nature of the heart. It's evolving, it's changing, it's erratic. Sometimes there's positive energy, sometimes there's negative energy. Sometimes you're energetic to do good, sometimes you're lethargic. That's the nature of the heart. In fact, when we talk about bringing iman on Allah subhanahu wa ta'ala, then there are 3 key components. Iqrar bil lisan, to utter with the tongue. tasdeeq bil janan, to believe with the heart, amal bil arkan, and to execute the obedience of Allah through your organs. Hence, if a person proclaims the kalima with his tongue but denies it with his heart, he is a hypocrite. He is a hypocrite. In fact, in the 14th juz of the Quran, in chapter 16, in Surah An-Nahl, Allah subhanahu wa ta'ala says that if a genuine believer's life is threatened, somebody comes to him and tells him, denounce the faith, utter a statement of kufr, and to rescue his life, momentarily he utters a statement of kufr, وَقَلْبُهُ مُطْمَئِنٌ بِالْإِيمَانِ, but at the very time of the utterance of a statement of disbelief, his heart was firmly anchored in belief with Allah, and his heart was aligned with Allah subhanahu wa ta'ala. Then there will be no consequences upon such a person. Why? Because Iman is accommodated in the heart. In fact, the Prophet sallallahu alaihi, of course, the manifestation is in the organs. The Prophet sallallahu alaihi wasallam said, "At-taqwa hahuna, at-taqwa hahuna." He said, "Taqwa is in the heart. Taqwa is in the heart." Wa ashara ila qalbi, and he pointed to the heart. The Arabic poet said something so amazing: "Nusailu mad-dawa'u idha maridna, wa da'ul qalbi awla bis-su'ali." When we are unwell or we're sick, be it heart-related or otherwise, we hasten to the doctor. If it's heart-related, we're going to a cardiologist. If we need surgery, it's a cardiothoracic surgeon. And we take active measures because we know that an ailing heart can be critical and can be crucial. But how often do we concern ourselves about the well-being of our spiritual heart? And believe it or not, my brother and my sister, Allah subhanahu wa ta'ala also speaks about a healthy spiritual heart and an ailing spiritual heart. Like we have a healthy physical heart and an ailing physical heart. So in Juz 19, in chapter 26, the chapter on poets, in verse 88 and verse 89, Allah subhanahu wa ta'ala says on the day of Qiyamah, "La yanfa'u malun wa la banun." Your sons will not avail you, your assets will not avail you. And verse 89 of chapter 26, إِلَّا مَنْ أَتَى اللَّهَ بِقَلْبٍ سَلِيمٍ, but the one who appears before Allah with a healthy heart. That's the literal translation. That's the verbatim translation. Of course, Ibn Abbas radiallahu anhuma, Mujahid, Qatada, Hassan Basri and others have unanimously agreed, Qalb Salim, a healthy heart here means a sound heart. And that's the heart of a believer in which there is Iman. And contrast this ayah with a verse in chapter 2, the 10th verse. Allah subhanahu wa ta'ala says, "Fi qulubihim marad, fi qulubihim marad." There is a malady in their hearts. There is a sickness in their hearts. Their hearts are unwell. They're not well. فَزَادَهُمُ اللَّهُ مَرَضًا, and Allah has increased that disease and that malady. And this refers to the munafiqeen and the hypocrites. Just as medically you will be told there are different levels of a sick heart. Some is not so critical, palpitations might not be so intense. You went up a flight of stairs, you broke a sweat, you lost your breath, you went to the cardiologist, he monitored you, he advised you, etc. Certain measures, certain discipline, diet, etc. And you will able to, regain your strength. Likewise, there are different levels of illness when it comes to the spiritual heart. So the worst is this here, that is hypocrisy. May Allah protect us. And then in chapter 2, in verse 74, Allah subhanahu wa ta'ala says, ثُمَّ قَسَتْ قُلُوبُكُم مِّن بَعْدِ ذَلِكَ فَهِيَ كَالْحِجَارَةِ. Then their hearts became hard. It became like stone. Nay, it was more hard than rocks and stone. And that is where your heart becomes so hard, you cannot cry. My brother, if you praying and you cannot tear. My sister, if you seen carnage around you and you seen people in abject poverty and crisis and it cannot make you tear, that's a red flag that your spiritual heart is in degeneration. It's dropping and declining. Jumudul aini min qaswatil qalb. If you cannot tear, that's a sign that your heart has become hard. Your heart has become hard. وَقَسْوَةُ الْقَلْبِ مِنْ كَثْرَةِ الذُّنُوبِ. And your heart becomes hard when there are excessive sinning that is taking place. Sayyidina Uthman radiallahu anhu said, لو أن قلوبنا طهرت ما شبعنا من كلام ربنا. If our hearts were pure, we would never tire reciting Quran. If you cannot read Quran for a long period, I'm afraid that is a reflection of an ailing spiritual heart. Rabi' bin Khuthaym, the great tabi'i, said, لو فارق قلبي ذكر الموت ساعة فسد علي. If I were to lose the thought of death for one moment, I consider that to be a fatal blow to my spiritual heart. I consider that to be totally destructive to my spiritual heart. أطهر أثوابي وقلبي مدنس. The poet says, I take pride in my aesthetics, in my cosmetics, in adorning myself. وَقَلْبِي مُدْنَسْ. But my heart is soiled. My heart is soiled. My brother, my sister, it is time we take active measures to monitor our spiritual heart and reform our heart. Let me leave you with a hadith and a quotation. The hadith appears in Tirmidhi, narrated by Anas ibn Malik, and yet the Prophet ﷺ gives us an exercise to monitor our heart. He said to Anas radiallahu anhu, إن استطعت أن تصبح وتمسي وليس في قلبك غش لأحد من المسلمين فافعل. أو Anas ibn Malik, every morning and evening, if you can monitor your heart and see that there is no antagonism, there is no rancor in it, there is no dislike in it for any of the believers, then do so. Monitor it morning and evening. Is my heart pure? Is my heart clean? Or am I harboring anger, antagonism, dislike? I have all this malice in me, grudges in me. That is not the heart of a believer. That's not the ideal heart. If you can monitor and see your heart is clean, فَافْعَلْ, do so. فَإِنَّ ذَلِكَ مِنْ سُنَّتِي, because this is one of my practices. وَمَنْ أَحَبَّ سُنَّتِي أَحَبَّنِي. And if you love my practice and revive it, you love me. And whoever loves me will be with me in Jannah. I'll leave you with this quotation, which I came across of Abu Idris rahimahullah. He said, لَقَلْبٌ نَقِيٌّ في ثوب دنس خير من قلب دنس في ثوب نقي. It is better for you, O my brother, and it is better for you, O my sister, to have a clean heart in soiled clothing than to have a soiled heart in clean clothing.
Thank you very much, Ida, for that. Jazakumullah khair, Sheikh Suleiman Mullah, for those sage advices about the qalb, about the heart, about the spiritual heart, the ailing heart. For those of you who are just joining us, we'd like to welcome you to the Islamic Medical Association's Webima on heart failure. We'd like to thank Novartis for facilitating it. Just to remind you, please, some housekeeping, make sure your videos are muted, make sure your videos are and your sound are muted. If you have any questions, submit them into the chat box. As you can see, the register for this evening's talk has been uploaded now onto the chat box. If you click onto the register, you can fill it in. There's a short little survey, and that's how we're going to access your details to give you your CPD points. The video that has just been played is now live on Islamic Medical Association's YouTube channel. The link will be posted a bit later. We're going to move on now from the ailing spiritual heart to the ailing physical heart. So our next speaker is then Dr. Ahmed Vachiat. From my side, he is the branch chairman of the Islamic Medical Association, an old and hard worker of the Islamic Medical Association, and someone that's very dear to the Islamic Medical Association. He's an interventional cardiologist based here in Johannesburg and a specialist physician. He works out of the Wits Donald Gordon Medical Center and the Millpark Medical Center. He's got a certificate in interventional cardiology, and throughout his registrarship and fellowship, he's been taking all the prizes. So it'll take me quite some time to read out his whole CV, and I'm going to ask him to forgive me for not being able to read out his whole CV tonight in the interest of time. I do have a copy of that, and I'm willing to part with it at a price. It might include some cholesterol-inducing chocolates, but I'm sure he can take care of that too. So I'm going to, without further ado, hand you over to Ahmed Vachiat, and he's going to discuss with us the heart failure optimization to achieve better physical outcomes for the heart, or for the qalb. I find it interesting that Maulana Suleiman Mullah talked about qalb. The root words of qalb means changing. And when it comes to the spiritual heart, we know there's lots of exercises to work on to basically improve your spiritual heart. And I think Ahmed is going to give us a talk now on how to remodel and sort out the physical heart so that we have more access to improving our spiritual heart. Ahmed?
Assalamu alaikum wa rahmatullahi wa barakatuh. Sayyid, can you hear me loud and clear?
You have to speak up a bit. We can hear you quite well, but just speak up a little bit.
So we thank the IMA, we thank the company for allowing us to give this presentation. And we had an excellent talk from Mulana Suleiman Mullah talking about the spiritual heart and how a spiritual heart can recover. In the same way, heart failure, whether it be due to numerous traditional risk factors, and we'll go through them, the heart can also recover. And where we use medical therapy in this has developed to quite an evolved stage. And we'd like to take you through this journey. If there are any questions, Zahir will field them and we can answer them towards the latter part of the talk. But please, we'd love to hear your comments. So how do we optimize heart failure management? Can heart failure be prevented? And can heart failure recover? Our main aim of patients with heart failure is to prevent, number one, mortality, and number two, morbidity. So as far as possible, we try to avoid hospitalizations for our patients with heart failure. Heart failure is an abnormality of cardiac structure and function. And this abnormality of structure and function leads to heart failure of the heart to adequately perfuse organ systems, most importantly, brain, kidneys. The weakening of the stiffening of the heart muscle over time leads to pump failure and insufficient delivery of blood around the body. So as you can see, the normal heart on the left side and a patient with heart failure develops this dilated ventricle, more importantly, the left ventricle. So some terminology related to the left ventricular ejection fraction. An ejection fraction is the amount of blood that is pumped out of the ventricle over the total amount of blood in the ventricle. So on echocardiography, we look at two parameters, mainly the diastole and the systole, and we come up with an ejection fraction. So a patient with a dilated left ventricle, as you can see on the image on the left, is what we call heart failure with reduced ejection fraction. A patient with preserved ejection fraction has heart failure, what we call HFpEF. These patients are typically older, women, patients with hypertension and atrial fibrillation. So I've got two case studies that I'd like to show. This is a patient that I've seen recently that came to hospital with chest pain. A patient, an elderly male, hypertensive, family history of coronary artery disease. ECG was normal just before 11, TROP-T normal as well. This patient had ongoing chest pain, and hence the referring colleague repeated the troponin and the ECG. The repeat ECG showed a ECG with sinus rhythm, and as you can see in lead V1, V2, some ST elevation. This patient was taken immediately to the cath lab and revascularized. The left artery was revascularized, and as you can see, the imaging on the left, a significant lesion of the proximal right coronary, and as you can see where the wire is, a significant lesion in what we call the PDA. So a patient that has urgent revascularization will recover his LV. In this case, the ejection fraction improved from 25% to 40% with inotropes and an intra-aortic balloon pump. The second case is an interesting case from last year. A patient with COVID that was COVID positive in August, referred by a pulmonologist Patient seen a pulmonologist as an outpatient with persistent fatigue. The patient was having dyspnea functional class 3, which is dyspnea over a short distance, difficulty walking about 100 meters, and leg swelling. The patient had a normal lung function test, no traditional risk factors, and no family history of coronary artery disease. This patient had an echocardiogram which showed the ejection fraction of about 40%. I show an image of the MRI that was done in August with a globally decreased LV contractility with hypokinetic segments. And what you can see on the aspect of the lateral wall, a bit of hypopigmentation, or what we call late gadolinium enhancement. This was typical of a myocarditis, and this patient was diagnosed with COVID myocarditis. I've seen this patient about a month ago. The LV has recovered, and she also had a repeat cardiac MRI, which showed an ejection fraction back up to 60%. This patient was managed with traditional remodeling therapy, but of concern of COVID, this patient had received polygam. We can discuss other ranges of heart failure that we have. This is a new term, the middle one, called heart failure with mid-range ejection fraction, as you can see in the column in the middle, where heart failure is now broken down into 3 categories. Heart failure, reduced ejection fraction of an EF of less than 40. Heart failure with mid-range ejection fraction 40 to 49. And heart failure with preserved ejection, an EF more than 50%. All of these patients would have signs and symptoms of heart failure, and as you can see, the next blood marker proBNP is crucial in the diagnosis. So a patient that has a proBNP less than 125 picograms per milliliter does not have heart failure. And in the same way, a patient with an acute presentation, a 98% sensitivity, a proBNP less than 300, this patient will not be diagnosed with acute heart failure. So proBNP is an important blood test that can triage patients in the casualty. So the important part of LV dysfunction or the myocardium is to diagnose, is this valvular? Is this coming from the pericardium? Is this conduction to system disease? And more commonly, is this coronary artery disease? So I'd like to take us through a brief outline, just discuss some risk factors. How do we diagnose heart failure, and what therapy and what's new in 2021? Traditional risk factors, especially hypertension, diabetes, dyslipidemia, smoking history, and a family history of coronary artery disease, needs to be screened in every patient. Blood pressure, a systolic blood pressure of more than 130 over 85, and as you can see, those are high normal, grade 1, grade 2, obviously grade 3 severe hypertension. The latest guidelines advise us to do a 24-hour blood pressure monitoring, especially in young patients or those that you're not clear on the diagnosis of hypertension. As you can see, the nighttime blood pressure does drop, but over 24 hours, your systolic blood pressure is more than 130, and if your diastolic is above 80, you are diagnosed with hypertension. We should go back and look at signs and symptoms of heart failure. Symptoms: breathlessness, dyspnea, orthopnea, difficulty lying flat, PND, reduced exercise tolerance, as our second nurse presented to the pulmonologist, a person that has fatigue and ankle swelling. Signs: an elevated JVP, hepatojugular reflex, the third heart sound, a laterally displaced apex beat, as well as cardiac murmurs. So the diagnosis of heart failure goes back to medical school: history and clinical examination, biomarkers, ECG findings, and echocardiography. We'll go through a nice flow diagram to show more on this. So risk stratification: a male patient, a patient above the age of 55, females above 65, postmenopausal, Those with those markers, dyslipidemic, a fasting glucose that's high, a patient with high BMI, and especially patients with family history need much more tight screening. Look for other symptoms, for example, weight gain, sleep apnea. Look for clinically, does this patient have atrial fibrillation? Go through the renal history and look for other features of atherosclerotic artery disease. Look for asymptomatic organ damage. The pulse pressure, ECG will show left ventricular hypertrophy. Echocardiography can pick up left ventricular hypertrophy. Some colleagues do carotid intermedia thickness and look at other signs of target organ damage. Look at the eyes, look at the thyroid, listen for murmurs, look for radial delay, femoral pulses, renal bruise, and other causes of hypertension. For diabetes, we had an excellent webinar the previous month by Dr. Nasreen, where we went through diabetes, and all of this is interrelated. Patient has a stroke, peripheral artery disease, renal failure, and also look into the eyes. So this is a patient that has suspected heart failure. As you can see, the top part of this flow diagram shows a patient that has an acute onset, where in the routine casualty case, an ECG is done, as well as a chest X-ray. An increased cardiothoracic ratio should, once a person obviously listens to the heart, takes a good history examination, an increased CTR is a good sign that maybe you should just consider doing a pro-BNP. Just doing a pro-BNP can triage a patient that do you really need to echo this patient, or can this patient be safely discharged? As we mentioned previously, when the pro-BNP is less than 300, this patient is unlikely to be having heart failure in an acute onset. In the non-acute onset, as you can see the bottom, that pro-BNP level of 125 is an important marker that we do to decide whether, again, this patient can be safely discharged or whether an echocardiogram needs to be done. Laboratory findings, basic findings, a full blood count, a UNE, a troponin, looking at the CRP, HbA1c, a lipogram, a patient that presents with shortness of breath, especially in our COVID times, a D-dimer, a thyroid, important to do, and a uric acid in the appropriate patient. Patients presenting with heart failure, we should look for, is this an acute coronary syndrome, where we see the rise in the troponin? Sepsis, is this a patient with a pulmonary embolism, any arrhythmia? Quite common infections. Is this a patient that has an exacerbation of COPD or any other metabolic derangements? So non-ST segment elevation, rise in the cause of a rise in the troponin occurs more than 50% of positive troponins. So one should look for other causes besides cardiac. So an ECG is a class 1 indication to do. Exercise stress test can be considered in appropriate patients. An echocardiogram is a class 2A recommendation, as well as carotid intermedia thickness. Which therapy should be used in 2021? So I've divided this into medical and interventions. With diuretics, I'm going to start off very simply. The simplest is Lasix. Lasix works for 6 hours. We usually give it twice a day. Can go up to, we usually start with 40 milligrams twice a day, go up to 80 milligrams twice a day, and even higher doses. Once the ceiling dose is reached, we can add on therapy, hydrochlorothiazide, spironolactone, which we'll chat about later. And once the patient is adequately diuresed, a patient has developed normal LV function, the Lasix and the diuretics should be tapered off because these don't have the benefit of the remodeling therapy, which we'll discuss further. Remodeling therapy, as Mulana spoke about the spiritual aspect of regenerating the heart, this is the essence of this talk. How do we remodel the heart? How do we get the heart function back to normal? So the medical therapy lays on the backbone of having a beta blocker, namely carvedilol or bisoprolol, and up titrating this to adequate doses that has been proven in trial therapy. ACE inhibitors and angiotensin receptor, natural lysin inhibitor, Entresto, the new kid on the block, is what we want to also discuss about, especially something new and it has numerous benefits. And importantly, diuretics, spironolactone, aldactone, given at a dose of 25 milligrams, is important both for diuretic and for remodeling effect. So starting but at the basics of hypertension, I've just put a slight brief slide on what does weight loss give you for hypertension. It will give you just a mild or modest 5 millimeter of mercury improvement in your blood pressure. A diet, also very minimal, but it is important. So a young patient, always consider treating the hypertension with non-medical therapy initially, reduce the sodium intake and reduce your fluid intake as well. Exercise will also have, you can say, a mild, maybe modest improvement of your blood pressure, but not a significant change. Different antihypertensives should be considered in different clinical scenarios. So I'll just go to, for time, I'll just discuss maybe one of the important ones. A beta blocker in the patient with myocardial infarction would be a hypertensive you'll think of, but beta blockers are not your best antihypertensive therapy. As you can see with heart failure, those are the drugs we mentioned, and you need to decide in which clinical scenario your patient fits. In elderly, you might reconsider whether diuretic really would be beneficial. This is more hypertension where a patient, you would think of a calcium channel blocker, diabetic ACEs and ARBs. In pregnancy, you'll need to consider which therapy is appropriate. This is not for heart failure, this is for hypertension. So for initiation of antihypertensive drug therapy, first-line agent should include a thiazide diuretics. This is for hypertension, a calcium channel blocker, and an ACE and ARB. When it comes, these are the combination therapy, which we won't dwell on for too long. So when we talk about heart failure, a patient with an ejection fraction, in this case less than 35%, we initiate therapy with an ACE inhibitor and a beta blocker. If the ejection fraction is still less than 35%, we add aldactone. If the ejection fraction is still less than 35 and the patient is able to tolerate an ACE and ARB, we add, and we'll consider whether an ARNI would be the next step. Patient that has sinus rhythm or left bundle branch block, we evaluate whether CRT or cardiac resynchronization therapy would be considered. And if a patient cannot tolerate his heart rate coming down, ivabradine or Corilan can be considered. Patients that are resistant and have resistant symptoms, one can then consider digoxin, ismonitrates, LVADs, or heart transplantation. So the ESC heart failure guidelines, these are the latest ones, and these will be updated at the ESC this year. Recommend replacing an ACE inhibitor or an ARB with sacubitril, valsartan, or Entresto in ambulatory patients with heart failure with reduced ejection fractions who are symptomatic despite optimal medical therapy with an ACE inhibitor, beta blocker, and a mineralocorticoid receptor antagonist. So the natriuretic peptides have a beneficial action in heart failure. Neprilysin degrades natriuretic peptides and other substrates, including angiotensin II and vasoactive peptides relevant for cardiovascular physiology. So you will have vasodilatation with decreased SVR, decreased pulmonary artery pressures, decreased pulmonary wedge pressures, decreases hypertrophy, and more importantly, we'll discuss the clinical endpoints. This is a slide that shows both sacubitril works on the neprilysin as well as valsartan working on angiotensin II. So the Paradigm heart failure trial was one of the largest trials that showed that Entresto had a 20% reduction in cardiovascular mortality on top of current medical therapy. And I think that's an important thing. Patients that were already on beta blockers, patients that were well controlled. These were the criteria: patients with the EF less than 40, high pro-BNPs, exclusion criteria: patients that had a history of angioedema, and I think importantly, the last slide, these are patients that didn't have ACS in the last 3 months of screening. So what they did is that it was a double-blind trial that randomized Entresto to enalapril, and these patients were followed up for a median of 27 months. And I'll show you how the ACE inhibitor was swapped with Entresto. So there's a 20% relative risk reduction of the primary endpoint of cardiovascular cause or first hospitalization for heart failure. And as you can see, the number needed to treat was quite low. There was also, as we mentioned, a significantly reduced cardiovascular mortality. The side effects mainly are hypotension with this drug. So one needs to decrease your diuretic and follow this patient up. But I find what was quite interesting was there was less hyperkalemia, which is important in our patients with other medication, namely spironolactone. As you can see, less renal impairment, less cough, but there was slightly more angioedema. So Entresto replaces an ACE or an ARB, and these are the 3 doses, 50, 100, and 200 milligrams. And one needs to halt the ACE for 36 hours after discontinuing ACE inhibitor or ARB therapy, then Entresto can then be administered. It's almost like a washout period. So in summary, the Paradigm heart failure trial showed the superiority of Entresto versus enalapril was demonstrated by a 20% reduction in cardiovascular mortality or heart failure first hospitalizations, a 21% reduction in first hospitalizations, and a 16% in all-cause mortality. So besides medical therapy, how do we regenerate the heart? There are coronary, valvular, and I'll show you electrophysiology methods to improve LV dysfunction. We have therapy nowadays where we do the angiograms through the hand, use drug-eluting stents, can break up calcium, can open up blocked arteries. Left main PCI is more common as before. Valvular, for heart failure, patients can have percutaneous aortic valve implantations. New clips, besides the aortic valve being percutaneously approached, the mitral valve is the next step. Patients with heart failure that have atrial fibrillation, that has a bleeding episode, one can consider left atrial appendage closure and omit anticoagulation. Electrophysiology, patients that have LV dysfunction, severe heart failure, left bundle branch block, a biventricular pacemaker or cardiac resynchronization therapy can be considered. And down the line, with patients with severe heart failure that you might not want to put in so many leads, even percutaneous pacing is now an option. And lastly, just for interest, I tried one of these recently, a robotic PCI in one of our labs, where it would be ideal in this current COVID period, but obviously reducing the risk of radiation for the operator. And this is the way cardiology is heading. And the last slide of interest for our audience regarding the benefit of heart. I think I've shown the slide before. This just shows a person that does meditate or takes the time to reflect of, in this study that was published in 2017, the prevalence of hypertension, diabetes, and depression in those that memorized at least 10 sections of the Quran were less likely to have hypertension, diabetes, and depression. So this strong linear association was quite interesting. Hopefully some more research like this can come out through the IMA. Jazakallah, I'll stop now for questions. Zahir, Jazakallah.
Jazakallah khair, Ahmed, for a very enlightening and interesting talk. I don't seem to be able to access the chat for the questions. Perhaps if you can monitor the questions, can I ask all the guests to please submit your questions to the in the chat box, and then we'll submit them to you. Perhaps, Ahmed, if I can just kick off, I think these Arnis seem to be sort of very new kids on the block. I think the first thing on most of the attendees' minds will probably be, is there a significant increase in cost between the Arnis and the ARBs or even the ACE inhibitors?
So the important part with these therapies is the medical aids are more likely to fund it with good motivation. Our main aim is to prevent hospitalizations, and avoiding patients coming to hospital obviously would be the biggest saving in cost. So if we can limit the hospitalization, we would benefit the patient. We would benefit obviously cutting down the cost because it is an expensive procedure. And more importantly, we want the patient to be on best current therapy. So I see this taking over your traditional ACE inhibitors. But our medical aid funders need to be also, and they need strong motivations from the cardiologist.
Yeah, I think, Ahmed, maybe the message of the remodeling needs to come through, especially from the family practitioners, so that they can explain to the patients that we're actually avoiding hospitalizations and sort of expensive interventions. And then as far as the sort of post-COVID era, I think in terms of the right heart issues and right heart failure as such, are you guys seeing any increase in patients with right heart failure?
So there's a lot of, you can say from the COVID era, the most common presentation is a patient who comes in with a mildly raised troponin, a pro-BNP that's raised, and the discussion is this patient having a myocardial infarction. Majority of these cases are all right heart disease, so moderate pulmonary hypertension. The few odd cases of LV dysfunction, as you can see from the case where we decided it was a young patient, we decided to go with the polygam issue. And acute coronary syndrome hasn't been a very common presentation, thank goodness. We do know that there's been an increased thrombotic risk with COVID. These patients are generally on routine anticoagulation, namely Xarelto, Rosalto, Clexane. The high-risk patients will be put on aspirin and high-dose statin. So those are the more common presentations, say, with COVID.
Yeah, I think just a follow-up question from Ismail, and then we'll take Bita's question. Ismail Mullah wants to know, would you comment on the role of anticoagulation in patients with pulmonary hypertension and right heart failure?
So anticoagulation is a definite yes for patients with pulmonary arterial hypertension. A patient that has the pathophysiology and pathogenesis of PAH is a thrombotic. Some you can say what COVID has a microthrombi. So definitely patients with PAH particularly need to be on anticoagulation. Besides this, type 3 pulmonary artery or pulmonary hypertension, heart, lung disease, patients with pulmonary embolisms, that's another criteria which patients would be on anticoagulation anyway.
Okay, thanks for that. And Tyre Mita wants to know, in diastolic heart failure with atrial flutter and fibrillation, will a pacemaker make a major impact, Salam?
It's a good question. So in diastolic heart failure, I think it's important that we try to just explain to the audience what's an easy marker to know that this patient has diastolic heart failure. So if we look at the left atrium, and if it's more than 5 centimeters or 50 millimeters, you would think of that like an HbA1c of diastolic heart failure. So how you look at the HbA1c and you know this patient has for the last 3 months had bad glucose control. Over time, if the left atrium is big, this patient has diastolic heart failure. So when you have a big left atrium, you're more likely to develop atrial fibrillation. And the more of atrial flutter is when you have a bigger right atrium. So atrial flutter would improve very quickly with a DC cardioversion post anticoagulation. Atrial fibrillation would need obviously anticoagulation, rhythm or rate control. And this question, will a pacemaker make a major impact? It's only if you're having a reason for the pacemaker. So the pacemaker would be either for conduction disease or having blocks, type, as you can, type 1, type 2, type 3, how severe the block is. And the pacemaker that we discussed early on is a different kind of pacemaker where you pacing both the left ventricle and the right ventricle.
So Tahir isn't shocked by that reply. Any other questions? While we're still waiting for more questions to come through, I think just remember, please fill in the form, the registration form. Remember, it's a way of us submitting getting your CPD certificates to you, and it's also a means of us getting some feedback from you. Any other questions? As with Ismail Mullah again, in patients with left heart failure with low EFs, are there ICDs indicated? And I think probably a follow-up with that, Ahmed, if you could just comment on reasons for or arrhythmias post-COVID, and should we be doing anything about those patients?
So both this, I think let's start off with Dr. Mullah's question. So an ICD is internal cardiac defibrillator. So almost the size of a pacemaker that's put under the skin. Ejection fraction less than 35% for ischemic origin, an ICD would be recommended. If the cardiac cause is non-coronary, for example, let's say a peripartum cardiomyopathy, or let's say a patient with COVID myocarditis that hasn't improved, the evidence is not clear that an ICD would be beneficial in these patients. So it's ideally for ischemic LV dysfunction. The second part of your question, Zahir, of COVID and arrhythmias, we've seen a lot of bradycardias with COVID. We've seen heart rates drop to 40. And as you know, Zahir, in your field with anesthetics, a lot of the times with the Presidex and all these other agents that we put on, these are making the patients more susceptible to bradycardias. From all the patients that we've seen in Milpark Hospital, none that I have seen needed a temporary pacemaker. They usually all recover their heart rhythm. And the second part of your questions of palpitations, palpitations is quite common with a tachycardia, heart rate more than 100. I've seen a lot of them settle just with a beta blocker. And those patients, if it's an outpatient, they have a bit of lethargy. Coralen, or one of the drugs that we discussed, ivabradine, would be an option. So I would start with a beta blocker, aim low, bisoprolol, 2.5 milligrams, make that BD if the patient's having symptoms at night, and try to wean off if the drugs are not indicated further.
Jazakallah khair, Ahmed. Can we get any other questions in the chat, please? So perhaps, Ahmed, if you can sort of just give us a little bit about the interventions as such. You mentioned, I mean, we've always been going on about cardiac synchronization therapy. Are you guys still doing quite a bit of that when it comes to heart failure?
When it comes to the heart management, we like to, in such a multidisciplinary field, so we try to specialize in specific fields. So what the interventional cardiologist, which I do, we do the interventions coronary, valvular, so the percutaneous aortic valves. The cardiac resynchronization therapy, those are mainly done by electrophysiologists, which study another 2 years after their training in cardiology. So we refer these cases to electrophysiologists in the big centers because they specialize in this field. And different colleagues would have more experience with the CRT devices. So I try to keep more focused to the interventional part of cardiology.
Okay, but obviously, I mean, the cardiologists themselves will be able to refer the patients on as required.
So basically, the referral will be from the physicians, GPs, cardiologists. And once a cardiologist feels it's appropriate to put in a CRT, then this gets referred further.
Jazakallah khair, Ahmed. Dr. S.M. Muhammad, I think the question has been answered, but maybe perhaps we can touch on that. I see Rashid has also asked the post-COVID tachycardia. What tests should a GP do, and when do you refer a patient on with a post-COVID tachycardia, or should they all be investigated further?
So a patient that sees you in the GP practice with a tachycardia, I think you need to do a few basic screening. Make sure the patient doesn't have a raised CRP, any secondary infections. The D-dimer is an important test to see whether this patient still would benefit from that ongoing anticoagulation. A pulmonary embolism needs to be excluded, especially females look for a thyroid function that could be raised. And majority of these post-COVID tachycardias usually will settle down. If a tachycardia doesn't settle down, definitely needs a further investigation and the cause of the tachycardia. So the blood tests, as we mentioned before, a pro-BNP with a tachycardia would give a nice separation of your patients to see those that have a chronic cause or possible heart failure reason for the tachycardia. And if the pro-BNP is normal and the patient settles down with, as we mentioned, a beta blocker or the tablet which we mentioned, Corolan, then I think that would be another option.
We've got another question from Nurain. She says, Assalamu alaikum. Any advice for someone diagnosed with mitral valve prolapse that is not currently being on any form of treatment?
Mitral valve prolapse is a common diagnosis, but overdiagnosed, and a patient that is not on any current form of therapy. The question you could ask is, do you really need to be on therapy? So what are your symptoms? Are you having tachycardias? In that case, you might benefit from being on a beta blocker. If the mitral valve prolapse is more than mild, these need to be followed up more carefully and referred to an appropriate surgeon if this can be repaired. And obviously, you try for repair more than replacement for the benefit of having less anticoagulation down the line. So I think a patient that has mitral valve prolapse needs more close monitoring.
Jazakallah khair. Any other questions? So I think, Ahmed, while we're busy waiting for more questions to come in, just to thank you for taking out your time and giving us a very comprehensive review of optimizing heart failure. And I think important for us, especially when new agents come to base, to understand the implications and the rationale behind cardiologists treating these with new agents. Sometimes we think maybe it's driven by industry or driven by other motives, and it's good to see where the thinking is coming from, so that when patients come back for step down or to follow up with their GPs and for their repeat prescriptions, they are able to make informed decisions. Ismail Mullah has another question. He said, would you like to comment on the role of nitrates for refractory heart failure with low EFs?
The nitrates, especially in our African population, is a good therapy to use, very low side effects. But this would only be an add-on therapy. As you can see, once a patient is on adequate beta blocker, the rest of the remodeling therapy, then only you'd consider adding nitrates. Remember, some of the nitrates can cause headaches and drop your blood pressure, so you want to make sure that you're not causing more harm than benefit.
Okay, and then we have another question from Muhammad Shaya. He says, how do you exclude autonomic neuropathy as a cause of your tachycardia post-COVID?
So COVID can affect you in many ways. As we mentioned, bradycardias, tachycardias. You'll need to look at how we look for normal autonomic neuropathy in our, for example, our diabetic patients. So looking at things like doing a postural change in your blood pressure, looking at your heart rate variability on the ECG, and also make sure you're not looking at missing other things. Is your patient adequately rehydrated? And is another cause besides COVID? I think that's the whole thing with COVID numbers coming down. Don't forget about our other chronic medical conditions.
Jazakallah khair. I think any other questions? I think we can probably start closing up now and wrapping up. We will take one or two more questions. I think for us, the important thing, Ahmed, we've done the spiritual heart, we've done the physical heart. I think the emotional heart is the problem. So we haven't begun healing from the emotional heart, you know. So I think our next talk, we'd have to get some people to tell us how to deal with the emotional heart. I see there's no other questions. So I just like to thank Novartis and Mary Ann and Ido Khobla for doing some good IT. We apologize for the video giving us some teething problems. As far as the video is concerned, there will be a link posted to our YouTube channel. So follow us there. That video is already uploaded on there. And inshallah, as soon as we have the recording of this meeting, we will try and make the presentation also available on our YouTube channel. There's just one more question from Muhammad Chaya. He says, Salams, could you give us a step care approach to managing diastolic heart failure or failure with preserved ejection fraction? I think it was on one of your slides, Ahmed.
So as we seen in that slide, that there's a lot of evidence for heart failure with reduced ejection fraction, when EF less than 40% in the trials. Heart failure with preserved ejection fraction, which is quite common in our elderly patients. The conventional therapy is there's not much evidence. Obviously, there is new therapy that's currently quite topical nowadays. But I would go back to saying, is this patient adequately diuresed? Have you taken control of the blood pressure and the diabetes? Follow up the renal dysfunction? And there hasn't been currently much out there. But watch the space. Our drugs that we've spoken about earlier, there's a lot of trial information that is now coming to the forefront where there is potential benefit with these drugs.
So Ido has posted the link for Sheikh Suleiman Mullah's talk or video. It's available on the YouTube link. Those of you that haven't signed the register, please sign the register. And as you can see this slide, just to give you a little bit of background, these are some of the projects that the Islamic Medical Association is involved in, especially this is the details for some of the projects we run out of the Joburg branch. We do mobility aids, and obviously part of the mobility aids with oxygenators is tagged onto that. We run primary healthcare clinics. Many of you might be familiar with our clinic in Orlando, in Soweto, next to the masjid. We do a lot of counseling, both video and online. Our renal dialysis project is starting to take off now, especially in the Gauteng region. Make dua, there's some news on this end, and inshallah we might be launching a unit or be involved in a project on renal dialysis. So if you feel you want to be part of any of these projects, there's our banking details. You can visit us on our website. You can contact Sister Kashifa, or you can look at us on the socials. Interesting project in Johannesburg also is our IMA Cataract project, where you can give the gift of sight. It's a nice way to be involved in projects where you can, in partnership with the Islamic Circle of South Africa, it's done by treating a lot of the government patients. It's a really nice project to get involved in and to contribute, and the results are very tangible, because I mean within a week or so that person goes from being unable to be seeing and very low function to being able to see and carry on with their normal daily lives. So if there are any questions, if there are any queries, please submit it to Sister Kashifa or to visit us on our socials and communicate there, and we'll try and take it forward. So just lastly, once again, I'd like to thank Novartis for this webinar. We'd like to thank Dr. Ahmed Vachiat for the speech and for the informative talk. We'd like to thank Sheikh Suleiman Mullah for always being there and giving us good advice, very topical advice and related to the topic that we are discussing. Just remember our next event, this Webima series, inshallah, we hope to continue with it. It's run on a national basis by different branches of the IMA, and your contributions are obviously then branch specific. Our next webinar will be next week, inshallah. I think it is with Dr. Randri, and I think it's got to do with renal. Ahmed, if you're still available for one more question, we've got a question here. I'm just going to quickly read it out before we finish off.
Yes, sir.
I don't know if you can see that it's hi doc. Have you heard of ECP or EECP, a US FDA approved treatment for heart failure? ECP or EECP, it's probably an acronym for something, I don't know what.
And I haven't heard about it, sir.
Okay, inshallah. No, perhaps Arya, if you can give us some more detail on this, You just forward it to us in an email and a WhatsApp to Sister Kashifa. We'll try and give you some feedback. Dr. Shakira Ismail is in up. Shakira, you can, I think, either if you can just unmute Shakira there.
They just need to unmute themselves. They have the ability to just press.
Okay, right. I think, Shakira, while you're unmuting yourself, Arya says that it's called external counter pulsation. The EECP, so it's probably some external. I don't know. I don't have any experience with that.
Yeah, no, I don't. We don't have any experience with it, Zaid, and I think it hasn't been in the forefront of evidence-based medicine, so we haven't.
Sorry, can I say something?
Yes, you can go ahead.
I'm Jamila Adam. I know it's external counter pulsation therapy. It's an in vitro therapy, and it's being used internationally. It's well recognized, and in this country also it has started, and it does work very well, because a lot of time patients that go to the normal cardiologist, and they when they have problems with heart problems and that kind of, they have to go for a bypass, so when they are asked to go for a bypass, they actually come for this external counter pulsation. They come and see this technologist. He's actually a clinical technologist, same field that I am, and I'm in charge of the program at DUT. And he is Dr. Rakesh Mohanlal, who is now in practicing and doing this. And they go to him, and they do come right. And there's lots of information that there is publications as well that you can go through and read about it and see how people have actually been treated with this, and they do recover. So that's one way of avoiding surgery and that kind of thing.
It's brilliant, Jamila. Perhaps if you can give us sort of just for some
I will send you some information.
And make it available. Yeah. Brilliant. Thanks very much.
Thank you. It's new in this country. That's it. Thank you.
Hello, Assalamu alaikum.
Salam, you can go ahead.
Okay, there's two questions. The first question I'd like to know is, how do you manage a patient with heart failure with preserved ejection fraction? The second question I'd like to ask is that post-COVID cases, we're seeing even young individuals that are post-COVID that may have had mild or moderate disease, and they're getting tachycardia post-COVID, even 2-3 weeks post-COVID. Suddenly they feel that they've got a tachy and they call us. How do you manage that?
Okay, Dr. Shakir, I think Dr. Ahmed has addressed both these issues. Perhaps if you can give us a quick summary again, Ahmed.
Yeah, so I think let's tackle that first question of the heart failure with preserved ejection fraction. So Entresto has been recommended. I don't want to go too much on the details of preserved ejection, but it has been looked in the Paraglide heart failure trial. I think obviously more work needs to be done. And as you can see, they separated heart failure into mid-range EF. So that EF that is borderline 40 to 49, there's much more clear delineation of these cardiac endpoints. So the heart failure with preserved ejection fraction is a more difficult condition to diagnose, and it's treating the underlying cause currently. That's our most important. So treat aggressively the diabetes, hypertension, stop the risk factors, and dyslipidemia. The second, just quick guideline of tachycardias, as we said, look for other causes of tachycardia, and if you can't find any other cause, do a pro-BNP. If the pro-BNP is raised, refer to a cardiologist for an echocardiography. And if you cannot manage with a beta blocker, I find that Corolan works very nice. Corolan is ivabradine, or works on the shift channel, the funny channel, and it's an excellent drug without any major side effects.
Jazakallah khair.
Sorry, one more question. I've heard of two patients. One is a colleague doctor, GP of mine, friend of mine, another patient that's had pericarditis post-COVID. Can you elaborate a little bit and explain us on that?
Pericarditis, looking at the changes on the ECG where you see concave ST elevation. If this is in the same keeping with a bit of pericardial effusion, these patients would settle very, very nicely with the course of colchicine and a short course of steroids. So I would give a patient a short course of prednisone and taper it over a month. And if majority of these cases settle without requiring any further therapy. So those are the two drugs that I found quite useful, colchicine and some steroids.
Can we get Mohammed Said Hashim to ask his question, please? Mohammed Said, you've got your hand up. Would you like to ask a question? Okay, I don't think he can hear us, so he's not responding. We have another hand up. It says Y&H guest. I'm not sure who you are. Just introduce yourself and ask your question, please.
Just from my side, for those of you that if you are trying to ask a question, just move your mouse over the screen and the little floating toolbar will pop up to the very left. You should see the little icon that's got a little microphone on it. If you click on it, you will see the stripe goes away and it means you've unmuted yourself and you can go ahead and ask your question.
So can we get Mohammed Said Hashim or Y&H? You can unmute yourself and ask your question, please. Okay, let's move to Dr. A.K. Desai. I see you have your head up. Can you ask your question, please?
Assalamu alaikum. Could you tell me what was the name of that drug you mentioned regarding, besides the beta blocker for tachycardia? You mentioned some drug. I didn't get the name of the drug, Ahmed.
Called Coralen. Coralen goes by the, that's a trade name. The ingredient is ivabradine, and we give them normally 5 milligrams twice a day. You can go up to 10 milligrams. It's a very safe drug. In heart failure, you'd only give that drug if your heart rate is above 70 and you're on optimal beta blockade therapy, namely carvedilol 25 milligrams twice a day or bisoprolol at least 10 milligrams. So if your LV function is normal and you, I would still give a beta blocker first, namely bisoprolol. And if there's any side effects of lethargy or you're not getting adequate control of your palpitations, then I would suggest Coralen.
Can you spell it for us, please, Ahmed?
I can type it in if you want.
It's Coralan.
Any other questions? I see Mohammed Said Hashim. Are you able to unmute yourself now? Nope. And Y&H guest, we're going to ask you to identify yourself and unmute yourself if you have a question. Marvin, Dr. A.K. Desai, is that your legacy hand or is that a different hand? Okay, I think it's gone ominously quiet. I think the people want to go to bed, work on the emotional heart. Okay, so then once again, I'd just like to thank everybody for joining us this evening. It's getting on now. It's already 9:15, almost time for bed. Once again, thanks to everybody for joining us. As is traditional, we'll conclude all our Islamic Medical Association meetings according to the Sunnah. We'll conclude with Surah Al-Asr. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر.